Greetings, friends. Welcome to Everyone Counts webinar, Accessing Health and Health Advocacy with Dr. Lisa Cooper and Dr. Chidima Ibe. I am Reverend Dr. Stacy Cole Wilson, the Executive Minister of Justice and Service for the Baltimore Washington Conference of the United Methodist Church. It is my honor to greet you and welcome you into this space. I just want to let you know that if you would like to tweet today, it's hashtag Everyone Counts. And to learn more information about the work that we are doing, please go to www.bwcumc.org/Everyone Counts. Just want to introduce to you today those who will be leading us in our time. We have with us today Dr. Lisa A. Cooper. Dr. Cooper is an international thought leader on health disparities and a 2007 MacArthur Fellow. Dr. Cooper studies how race and socioeconomic factors shape patient care and how patients and health systems with communities can help at-risk populations. She is the principal author of over 200 publications and has been the principal investigator of more than 15 federal and private foundation grants. She's an elected member of the National Academy of Medicine, a Liberian-born general internist, and social epidemiologist. Dr. Cooper founded and directs the Johns Hopkins Center for Health Equity, where she and her team work to identify interventions that alleviate racial and income disparities and translate them into policy changes that mean better health for communities. She was named director of the Johns Hopkins Urban Health Institute in April 2020. Dr. Cooper received her BA in chemistry from Emory University and her MD from the University of North Carolina at Chapel Hill. She completed her residency in internal medicine at the University of Maryland Medical Center. She received her MPH from the Johns Hopkins Bloomberg School of Public Health while completing her postdoctoral fellowship at the Johns Hopkins School of Medicine. Dr. Cooper is blessed to have the love and support of her wonderful family and her church in Columbia, Maryland, where she serves on the Church Council and the Missions, Outreach, and Social Concerns Committee. Dr. Cooper has been a member of the board of directors at the Wesley Theological Seminary in Washington, D.C. since 2020. Please help me welcome Dr. Cooper.
Thank you, Reverend Wilson.
Thank you for being here with us. I'd also like to welcome to this platform Dr. Chidima Ibe. Dr. Ibe's research focuses on the use of community health workers to reduce cardiovascular disparities in underserved, disenfranchised communities. She has experience in the development, implementation, and evaluation of community-based healthcare delivery programs and has collaborated with community-based organizations to develop innovative strategies for health promotion in the greater Baltimore area. Dr. Ibe is an assistant professor of medicine in the Division of General Internal Medicine at the Johns Hopkins University School of Medicine and the associate director for stakeholder engagement at the Johns Hopkins Center for Health Equity. Dr. Ibe received her BA in Health and Societies from the University of Pennsylvania and her PhD from the Johns Hopkins Bloomberg School of Public Health. She is the first generation American of Nigerian ancestry and is indebted to her family for instilling the values of faith, compassion, and social justice. We greet you into this space as well, Dr. Ibe. Thank you for being here with us.
Thank you so much. It's my pleasure.
At this time, I invite all gathered in this space to just take a moment as we center and acknowledge the presence of the Most High God here with us and pray for persons across the nations. Gracious and eternal God, we honor your presence. We thank you for being mindful of your creation. We thank you for knowing us by name. We thank you, O God, for meeting us at the point of our need as we intercede for your children here and around the world. Wonder-working God, Alpha and Omega, resurrection and the life. We trust in you. We lean not to our own understanding, but in every way we acknowledge who you are. Lead and guide us. We shall wholly follow you, and we honor you. It is in your name that we offer this prayer, along with the cries, groans, and yearnings of your children here and around the world. Amen. I now turn it over to our presenters. Thank you.
Thank you. All right. Well, hopefully everyone can see our screen now. It's our pleasure to be with you all today to talk with you about accessing healthcare and addressing health disparities in a COVID-19 era. So this is just an overview of what we'll be talking about over the next 30 minutes or so. We'll define health disparities and health equity. We'll describe how long-standing disparities have contributed to disparities in the impact of the COVID-19 pandemic on communities of color and other vulnerable groups. We will then highlight best practices for communicating in a public health crisis, and then discuss ways to care for ourselves, our loved ones, and our communities. So first, we're going to start out by just defining some key concepts and making sure we're all on the same page. When we talk about health disparities, what we're talking about is preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. This is one of many definitions of health disparities. When we think about health disparities, what we contrast that to is our vision, which is of health equity, and that's when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. We're going to talk more about what some of those circumstances are and how they've actually played out over the years to create these disparities. But what we do know is that health disparities are widespread, that they occur across numerous conditions. You can see them all listed on this slide, and there are even more. They occur across populations, all the way from infancy into older age. They occur in men and women. They occur across multiple settings, rural and urban, and across multiple healthcare settings. And so this has been going on for many years and has been documented in the health and public health literature, particularly over the last 20 to 30 years. Now, right here in Baltimore, we're close to where we are, we've seen this pattern, and we've seen it in a number of other US cities where within a short distance, we see huge differences in health. So these are two neighborhoods in Baltimore, and you may have heard of many of these if you are in Baltimore and near there. But Roland Park is a neighborhood that is approximately 80% white. The average annual income is about $90,000 per year. Unemployment before the COVID-19 pandemic stood at around 3.4%. The homicide rate was pretty low, 4.1 per 10,000. And the average life expectancy at birth was 81.3 years. You can contrast that to a neighborhood just 5 miles away near the Johns Hopkins Hospital where Dr. Ibe and I work. That neighborhood is 90% African American. The average annual income is about a third of what it is in Roland Park. Unemployment is about 3 times higher there, and it may be even higher at this point in time. The homicide rate is 10 times higher in that neighborhood. And you can see there's a 20-year gap in life expectancy at birth. So that means if you are born in Madison East End, you can expect to live to be about 65 years old. But if you're born in Roland Park, you can expect to live to be 83. So that is a huge disparity. And you can see we just provided one example from heart disease, which shows you the death rate from heart disease is about 3 times higher in Madison East End as it is in Roland Park. And you could take this map and actually replicate it for numerous cities. Washington, D.C., there's a very similar map for it. Chicago, New York City, Los Angeles, and you would see very similar patterns. So in order for us to address health disparities, though, we have to understand how they exist and how they came to be. And so this map basically shows you that, health disparities exist for numerous groups in our society, particularly people of color, people with low income, those who live in urban areas as well as in some rural areas, people with different types of physical and mental abilities. And we know that women tend to be disproportionately impacted by health disparities as well. For some conditions, and for some conditions, it's for men. So these disparities are complex because they are caused by a number of different factors that interact with one another, starting all the way at the top from the social conditions in which we find ourselves, the economic policies we have as a nation, the physical environment when you think about things like exposure to air pollution, for example, or even unsafe drinking water in many cases. I know many of you are familiar with the situation in Flint, Michigan. Institutional factors contribute to disparities. We know that there are differences in hiring practices, for example, and in what wages people are paid in different institutions, different types of policies that impact people in these different groups differently. There are health system factors, and I became really aware of these factors when I did my medical training and was going through my residency training. And that's actually what drew me to the career that I chose and the desire I had to work in public health and in medicine, addressing inequities in healthcare. Social relationships are part of the problem. We've seen a lot of discrimination that has been brought to light in recent times. We know that there's crime within certain neighborhoods, and those kinds of relationships, the negative aspects of those relationships tend to impact people in disparity groups at a much higher rate. We know that there are also risk behaviors. People choose, for example, to smoke or to drink alcohol or to engage in other forms of drug abuse. They also may overeat and become obese. And there are biological factors. They're just things that we are born with or that we inherit that contribute to health disparities. But for the most part, the disparities are caused primarily by factors at the top of this box, and that they just sort of all then tend to shape the types of choices that people have to whether they can engage in healthy behaviors or not. So, for example, if you live in a neighborhood where there aren't that many healthy food options, even if you wanted to choose to eat fresh fruits and vegetables, you might not be able to do that because you might not have access to it. And so a lot of these biological and risk behaviors are really shaped by the rest of the factors that have been determined over many, many decades and even up to over a century. So we're going to shift now a little bit to talking about the current situation in which we find ourselves and why it is that we're saying that COVID-19 is actually the great unequalizer, because it's actually shining a magnifying glass on health disparities. So first, we won't spend too much time on this because I'm sure a lot of people have heard a lot about this in the news, but what is COVID-19? It's an illness caused by a coronavirus, which is a type of virus that causes both human and animal illnesses. It's very highly transmissible, and it causes diseases that range from very mild to life-threatening. The most severe cases require hospitalization and supportive care, for example, with respirators. People who are male, older, or have underlying health conditions appear to have a higher risk of severe illness with the coronavirus infection. Now, this is a new coronavirus to humans because it actually occurred in bats, and then it sort of changed itself and crossed over into humans. And that's one of the real problems with this new virus, is that no humans have had immunity to it prior to now. And that's what has caused it to be such an overwhelming problem and has caused it to turn into a pandemic. The most common symptoms are fever, cough, shortness of breath, chills, muscle pain, headache, and sore throat. But actually, a new study has shown that the most common symptom is actually loss of taste and smell. And even though that symptom occurs in other illnesses, it is so specific that it's now been determined that if people are coming in or experiencing loss of taste or smell, that in and of itself is an indication for getting a COVID-19 test for it. So where are we now? This was just taken from the Johns Hopkins Coronavirus Resource Center map, which many of you may have been tracking. You can see that worldwide we're over 4 million cases at this point in time. We're close to 300,000 deaths globally. And the United States is actually leading in the number of cases and deaths across the world. The other thing we're seeing here is that in the United States, we have certain areas of the country that are disproportionately impacted. And those areas are shown in the sort of the dark maroon color. So we know we've heard a lot about New York City and how much it's been impacted, in Boston. We've heard about, for example, New Orleans, Louisiana, where there's a strong outbreak out there. We have Las Vegas, Nevada, where we're having a huge outbreak. And then we have here the top counties on the left side of the screen. And most of these are in New York State, around New York City, and then some around the Los Angeles area. So what do we know about how this pandemic is impacting vulnerable populations and health disparity groups? So these are the vulnerable populations and groups with health disparities in the US. We talked about that a little bit before. Predominantly people of color or people with low income are impacted, but also immigrants, also women and children who tend to be also disproportionately impacted by low income, older adults, people who are homeless or housing insecure, people with multiple chronic conditions, and a number of other groups here. You've heard a lot about the outbreaks in nursing homes and assisted living facilities, because we have a huge number of older individuals with chronic conditions that are in close proximity to each other. And then you've also heard about outbreaks in correctional facilities. So we have a lot of vulnerable groups in the US that are at risk for health disparities on any given day, but because of this pandemic, they're at even increased risk. Where are the states that have been most impacted so far? We're just gathering data about this. There are some states that have not been reporting this until a lot of policymakers started really calling for this information. And so you can see on this slide that Michigan, Illinois, North Carolina, and South Carolina were reporting the percentage of COVID-19 diagnoses that were African Americans relative to the percentage of African Americans in that state. And you can see that the blue bars are showing you the percentage of COVID-19 diagnoses that are African American. And in every case, the blue bars are higher than the gray bars, meaning that African Americans are overrepresented among the people being infected. There are numerous states where we're seeing this happen. We're seeing in Alabama, Illinois, Louisiana, also in Mississippi and Missouri. Several specific cities and counties. Baltimore, Maryland is on that list, sadly. And then we also see Milwaukee County, Wisconsin, Richmond, Virginia, Chicago, Illinois. So these disparities are nationwide at this point in time. The other thing we see right here in Maryland is that not only the number of cases, but the number of deaths are greater relative to the population among African Americans than among whites. We're not seeing that same disparity in our state with regard to Hispanics yet. But if we look at specific zip codes, for example, like in Baltimore City, we're seeing even more dramatic disparities among African Americans and Hispanics in particular. Now, in other places around the country, we're seeing disparities for other groups, such as in some parts of, like in Arizona, for example, American Indians are disproportionately impacted. In some areas in California, we're seeing Pacific Islanders, particularly Filipino Americans, being disproportionately impacted. And everybody may be wondering, like, well, why is this? And so we'll talk a little bit more about why that is. So here are some challenges that these health disparity groups experience on any given day that are magnified at this time. So people may lack access to basic resources, such as food, water, shelter, and transportation. We know that many children, for example, are dependent on the school lunch program, and with schools being closed, families may not have access to food at this time, especially when they're being asked to stay at home and not to go shopping or being told that they should go shopping and stock up food for 2 weeks, and everyone can't afford to do that. People may be living in suboptimal housing conditions. We know in many communities of color, there are multiple families living within one home, in smaller homes, especially in immigrant communities. We know that the employment in essential professions with limited protections and limited paid sick leave is much higher in communities of color. So we have a lot of people from communities of color working in frontline jobs, such as being bus drivers, working as health home aides, working as custodial workers, and they're out there. They're working in grocery stores. So we can see why this problem could be magnified for them at this time. They tend to lack access to healthcare services, and be insured at lower rates, and be more dependent on public insurance. And understandably, there's a mistrust of institutions due to discriminatory experiences. So many people may hesitate to follow the guidelines and recommendations of government officials or public health professionals because they may be questioning whether this is truly in their best interest. And we'll hear more about some of those questions that people may have. So these are just a small sample of some of the articles that have been, there've been so many articles that have been coming out in the media showing the reporting, all these disparities in death rates and in infection rates. And you can see the map in the center is showing all the hot spots in New York City, and the neighborhoods that are disproportionately impacted tended to be mostly minority. They were in the Bronx, New York, they were in Staten Island, and not so much in Manhattan, where it's mostly higher income individuals and whites. And someone wrote a very poignant article about social distancing and the fact that it's actually a privilege, and that so many people don't have the privilege of staying at home and staying away from where they might be exposed to other people at this time, because they have to go out there and work, because they have to go out there and buy food more frequently. So my colleague Josh Sharfstein and I wrote an op-ed piece directed at policymakers actually a few weeks ago, where we outlined some basic suggestions, because we really feel that there's a lot that we as individuals can do, but there are a lot of structural changes that need to be made and policy-related changes that need to be made to help address this issue right now, and then also long-term. So, but this paper was basically about the game plan that we need right now, and that is to do a better job of tracking data on our cases by race, ethnicity, and geography. That leaders and policymakers need to work on communicating and building trust with communities of color. They need to work on enhancing access to testing and healthcare for these groups. They need to focus on protecting essential and low-wage workers at this time. Make sure these individuals don't get fired if they take time off because they're sick. Make sure they get paid hazard pay if they're out there putting their lives on the line. Make sure their employers provide protective personal equipment for them to wear, and require other people who are using those businesses to similarly to wear masks and to remain a safe distance away from these employees. And then finally, to really focus on providing essential social services to these vulnerable groups, making sure there's food delivery, making sure that SNAP benefits are extended and people can use them for essential products, not only food, because at this time we know people need other supplies as well. Working to make sure people's utilities don't get turned off, and that they don't get evicted during this time. So there are so many policies that can be put in place immediately, and then we also have to look at the long term. So I'm going to transition now and have Dr. Ibe talk with you about how do we communicate during a public health crisis.
Thank you, Dr. Cooper. Thank you for doing such a great job of highlighting the landscape of disparities in the United States and how they've really amplified what we've observed with the COVID-19 pandemic. And I think at this point, it's appropriate to consider the fact that we are not in control of, but we are in control of how we communicate with one another about what is essentially a public health crisis. So one of the things that we can do is to be first in the sense that we are abreast of what is happening with the pandemic and provide regular updates to one another, and in particular to those who have the privilege of leading faith institutions, to your congregants. Also to be right in the sense that we're not overly reassuring what we know, but we're focusing on the facts. And that is very closely linked to being credible, that we're linking up with local experts to provide additional voices to the messages that you're disseminating. I think this fourth bullet or fourth point about expressing empathy is really in the sense that we are all part of a shared humanity that is something that many of us have never undergone in our lives. And expressing that we want to hear from what other people are saying and understand the concerns that they're expressing. At the same time, we want to promote action. And I will speak for myself personally and say that it is tempting to think that there's not much we can do. And it's very important to convey to one another that there are things that we have some control over and certain actions that we can implement in the face of something that may seem completely out of our control. Finally, we also want to make sure that we're showing respect. In some instances, in an age where there's a lot of misinformation that has circulated about this pandemic, it's really important that we show respect to one another, even in the face of diverging opinions about the sources of COVID-19 and how best to tackle this pandemic. We also want to make sure that we're communicating that this is indeed a serious threat to the health of our community and not understating the fact that it is a novel coronavirus and we don't have herd immunity and we don't have a vaccine or other mechanisms in place to properly protect ourselves the way that we may have for other conditions. We want to convey that everyone does need to do their part to reduce the spread of this new virus. It's also important to bear in mind that we are communicating with one another that it's possible to spread this disease despite not showing any symptoms, and it reinforcing the importance of maintaining social distancing. We're trying to do so in order to protect the most vulnerable among us, whether they are those who are elderly or those who have underlying conditions that may predispose them to additional suffering from this condition. We also want to make sure that we are helping people understand that they should stay home when they're sick, that they should wash their hands regularly with soap and water for at least 20 seconds, that they cover their coughs and then reduce their social interactions or limit their social interactions. It's important that as leaders in our communities that we convey that the actions that we are taking are difficult. I think there hasn't been anyone that hasn't been touched by the difficulties of not seeing loved ones or being able to communicate face to face with people that we may miss. At the same time, these are actions that are really necessary to protect the health of our community at large. And also that when we do these things together, we will be able to make it through what has proven to be a difficult time. We also have a responsibility to refute some of the falsehoods that have emerged during this pandemic. Over the next set of slides, we'll just highlight some of the major ones that we've noticed. One of them being that a disposable face mask in and of itself will protect you from COVID-19. We know that that is actually not the case. So for the general public without respiratory illness, wearing a lightweight disposable surgical mask can still allow tiny infected droplets to get into the nose, mouth, or eyes. The reason for the masks, however, is that it could keep you from spreading the virus to others if you do have it and are asymptomatic. So what the Centers for Disease Control recommends is that you wear cloth-based coverings in public settings where other social distancing measures are difficult to maintain. So for example, when you're going to the grocery store or to the pharmacy, these are sites where community spread is likely to happen, and that's why wearing facial coverings is essential. The other falsehood that has come out is that young people do not have to worry since they are less likely to get seriously ill. Now, I do want to acknowledge that this is a falsehood that does make some sense, in that in the early stages of this disease, before we understood the contours of who it affected, there was some indication that younger people were not as likely to get it or to have less severe symptoms. We actually now know that that's not the case. Young people can get it and can become quite ill, and they can also spread it to older and more vulnerable family members and neighbors. We also know from emerging evidence happening that has been monitored in New York that there's some instances of children coming down with some rare additional conditions that are associated with COVID-19. We know for sure that this is not something that young people don't have to worry about. This top point is something that we've actually seen disseminated not only here in the United States, but in other countries, which is that gargling with bleach or salt water can protect you from COVID-19. That is absolutely false. Gargling with bleach or salt water or ingesting disinfectants will not protect you from COVID-19. In actuality, they're dangerous practices that can make you sick. There's another myth that has come out, which is that the new coronavirus was deliberately created or released by people. There have been a couple of studies that have demonstrated that this is not the case. The other thing that we know from the way that viruses emerge and transform over time is that it's not uncommon for a disease outbreak to happen where it is common in a specific animal and then kind of jumps to human beings. So the evidence that we now know about this novel coronavirus is that that is indeed the way that this came. The other thing that some of the things that you are seeing here come from the Mythbusters slide, Mythbusters information from the World Health Organization. It was initially thought that the novel coronavirus wasn't able to be transmitted in hot or humid areas, but we know for a fact that it can be transmitted in all areas. And when you recall the map that Dr. Cooper showed about different hot spots throughout the world, some of those regions are in hot and humid areas and still have cases of the novel coronavirus. It's also thought that if you can hold your breath for 10 seconds without coughing, you don't have COVID-19. This is also false. The best way to confirm whether or not you have COVID-19 is through a laboratory test. You can't really confirm it through this breathing exercise. And in fact, holding your breath for extended periods of time can impair your health. So now let's think about what we can do to help ourselves and to help one another. So one of the things that we can do to take care of ourselves and our loved ones is to wash our hands, as I mentioned before, with soap and water for at least 20 seconds. I also mentioned earlier to limit the extent to which you're outside, so limiting your errands, which I think is difficult for many of us who are used to being on the go. But we need to be careful about how often we're going outside and reducing our exposure to other people. In a similar fashion, wearing a mask every time we go outside, especially when we're in public settings where social distancing is more difficult to implement, is a really critical way to take care of ourselves and to protect our loved ones who we may be living in the same household with. One key way that we can also take care of ourselves is to continue to take medications that have been prescribed. So a number of us have underlying health conditions, and it's all the more important to guard our health at this time, given that we may be more susceptible to adverse experiences with COVID-19. One of the things that we can do to take care of ourselves is to get fresh air and to exercise every day if possible. I really have to doff my hat to my parents. They're very good at doing this. They live in Massachusetts and they go for daily walks and walk for several miles a day. I'm trying to implement this myself. The other thing that we can do to care for ourselves and for our loved ones is to follow a healthy diet. And cooking helps with ensuring that we're able to take in proper nutrition. It is difficult to do this when we are feeling stressed out, but it's very important to try to get enough sleep each night. And I think the amount of sleep that we get, the optimal amount of sleep may differ with each person, but generally speaking, 7 to 10 hours is really recommended to kind of restore our bodies and allow us to ward off disease. Another key way to care for ourselves is to manage stress, and there are a number of ways to do that. For some people, cooking and exercise is a critical way to help manage stress. For those of us of faith, prayer and meditation is another strategy that we can employ to help manage the stress that we're feeling during this period. Reaching out to loved ones, whether it's through phone calls or emails or texts, is another critical way to stay in touch with one another and encourage each other during this period.
Well, I'm going to come back in now just to talk about advocating for yourself and your loved ones when you're seeking health care. A lot of people have talked about how difficult it is right now to engage with doctors and nurses because everyone is so overwhelmed with the COVID-19 crisis, we realize that people still have other health concerns. There's still regular problems going on and people need attention for, their current conditions, or something may happen. They may fall, or they may have a bad sore throat, which may not be COVID-19. So there are so many things that we need to keep in mind at this time. So for your medical visits, which many people now are using telemedicine, and that's a whole other concern and another contributor to health care disparities. By the way, we know that in a lot of communities of color and low-income homes that people don't even have access to broadband internet or to smartphones where they can have these sort of video visits with health professionals. Fortunately, most people do have a cell phone and providers are available by phone, but we know it's really challenging around this time. So it's very important. This is important at any time, but particularly important right now is to prepare for your medical visits. Think about what you or your loved one's symptoms are and what your questions are. Write them down. Know the tests that you've had and the names of the providers that you've seen so you can share that information. It'll save time when you're having a visit that may not be like the type of visit that you would have had if you could have gone in person. Once you're in there, you need to act, or you're interacting on the phone, or you need to make sure that don't be afraid to ask questions. I think that it can be intimidating at times. Health professionals seem really busy. They seem really stressed, and we don't want to bother them and that sort of thing, but that's their job. And so it's important for you to ask questions, to be as open as you can about what you're experiencing, what your concerns are. Same for your loved one, so that the care team can know how best to help you. So really, you're a team member with that healthcare, with the health professionals, and actually you're the expert on your own body. You and your loved ones are the experts on yourselves. So we call this doing your part. So the P is prepare, the A is act, R is to review any recommendations you get. Make sure to tell the provider what is your understanding of the care plan. So a lot of times, we think we understand something, but if we don't really clarify what it is, it could be that we didn't really quite get what we were supposed to get. So we call this, on the providers, and we call it teach back. And what they're supposed to do is to ask you, can you tell me in your own words what our plan is and what you intend to do? But if they don't ask you, you just speak up and say, okay, this is what I understand from what we talked about today, and this is what I think I'm supposed to be doing this, and I want to make sure that I've understood everything you've said. So, and then if that's not correct, make sure you get your questions answered. And I know sometimes it seems like it's rushed, but you got to try to slow people down so to make sure you get your questions answered. And then also, it's okay to call back. If you get home and you can't remember or you got confused. So do your part. The T is to take the recommendations home and to help your family member or loved one, or you yourself to commit to doing the things that you talked about. I'm going to turn it back over to Chidima for this part.
Thank you. So the other thing too that we wanted to highlight is, in keeping with the theme of shared responsibility and community and thinking about how we can help one another, is to really think through what we can do to identify the needs that our friends and family and congregants and other community members may have. I think this is really critical in the sense that churches have really stepped to the plate and have had a history of doing so in times of public health crisis for helping community members address their needs. So when we think about what types of things we could identify, one is to think about medical concerns. So asking one another whether or not the other person is worried about things related to their health and worried about getting their medications. The other concerns housing instability and the conditions of the homes in which our community members and congregants and even other loved ones may be residing in. Especially identifying worries about having a place to live or issues with where they live, where the conditions may make them feel unsafe or just cause general worry or concern. Something that Dr. Cooper and I, as well as our colleagues at the Center for Health Equity, think a lot about is the issue of food security. We work in East Baltimore, which is an area of food deserts and food swamps. So areas where there aren't a lot of the access to fresh groceries and healthy foods is lacking in many ways. And then access to unhealthier foods, which is a food swamp, is more prevalent. So really asking one another if there's enough food in the home and whether or not they're worried about buying food or whether or not they can afford the food rather, and then buying the food at the store. And I think this is something that has really come up a lot when we think about or think of the images we've seen of people clearing out grocery stores and what that means for those of us who are less advantaged and able to buy food when we may need it. There are also transportation needs. So whether or not the individuals that we are talking to have transportation, are they required to attend work? Do they have urgent medical or dental appointments, and are they able to get to those appointments? Some of these institutions are closed right now, but as social distancing measures ease up throughout the more people will be able to attend dental and medical visits, and thinking about whether or not they're able to access them through transportation or even getting to the store for supplies and food. Some of the other things that we think a lot about when in terms of identifying needs and trying to address them are utilities. So do our friends and neighbors and other loved ones have needs related to electricity, water, gas, or internet? Social and emotional support, which is proving to be really critical at this time where so many of us are in our homes. Some of us are in our homes by ourselves and are not able to see our loved ones face to face. But whether or not the people that we're talking with and trying to support have someone that they can talk to if they feel alone or isolated, or even if they feel safe in the homes in which they live. Employment has certainly emerged as a major issue, with so many people being affected by the economic downturn that has occurred as a direct result of COVID-19. Asking each other whether or not we've been laid off or furloughed and what some of the implications of that are, as well as whether or not you're concerned about or furloughed.
So we're getting close to wrapping up here. So here are some of the things that we've been involved in at the Center for Health Equity, and we're sure many of you as faith leaders have been involved in as well. But how do we care for our communities? We make sure to maintain 6 to 8 feet of distance from others whenever we're out and about, wearing a mask when we're in public. We commit to not hoarding food and other essential supplies so that everyone will have enough. We support organizations that provide community services. So give to food pantries, whether it's financial or whether it's actual food and supplies, to shelters, to schools. You can see here one of our center members was did a grocery delivery to one of our community partners in East Baltimore. And he was so grateful. There are so many people that were in need. Call to check on people who you know live alone or might need some extra support at this time. Show your appreciation to essential workers. You know, people are out there putting their lives on the line. We shouldn't be taking them for granted at all. Advocate for them to get paid, hazard pay. Thank them whenever you see them. Support policymakers. This is really important, who advocate for vulnerable groups in our society. In other words, go out and vote. Don't stay at home and don't think that, that it doesn't matter, because it does matter. This is what actually determines, who is able to survive and be healthy and who's not. So our center has a resources page. It's at www.healthequityhub.com. You'll see the link for our COVID resources page if you need additional information. We have it broken down by, the audience, whether it's healthcare professionals, community, or patients. And we just wanted to share this photo with you of our team that we took earlier this year when we sent out our New Year's message of healing, health, peace, and justice in 2020. And we're still standing strong by that belief and that hope and that vision. As many of you know, God is powerful, and with him, all things are possible. So we wanted to leave you with that message and to just leave you with some of our contact information here. You can tweet about this presentation or reach out to us if you need to. And we look forward to having some questions from you now.
God bless you. Thank you so much, Dr. Ibe and Dr. Cooper, for this excellent presentation. We're so grateful to have you here. We definitely invite you to share your questions, those who are watching remotely and those who've joined us online or by the phone. Thank you so much for all the information that you've shared. It has been incredibly helpful. Thank you for teaching us about how we can do our part. And we know that this is such a busy time. We know that Senate hearings are happening now. We're talking about the testing that is to come, the accessibility that is needed. And so I will just share with you two questions just to make sure that the persons who raised these have if there's any additional information that you'd like to share. One question was, what can our churches do now or in the future to address the health disparities you outlined? I believe you shared some information on that. And to Dr. Ibe, what is the timeline for everyone to be tested in Maryland? Do you have any updates?
Oh, so I think, I think that's going to be, it's a process. We've gotten a lot more tests through Governor Hogan, who made that effort to order supplies from the U.S. for us. But testing is still not available to everyone. Right now, there's a focus on testing high priority populations. So, for example, people who live in settings will have priority. People who are high risk will have priority for testing. And more than likely, what is going to happen next is that frontline workers are going to have priority, because they're the ones that are going to need to be out and about and interacting with others. So it will gradually expand over time. And for now, though, if you are, not extremely ill, and if you're not at risk for spreading the infection to others, you should still reach out to your primary care provider, because these recommendations change very frequently, and it could be that by the end of this week, it's all going to be. But at this point in time, the priority is going to be rolled out to different groups over the next few weeks.
Thank you. Thank you.
I appreciate Dr. Cooper's answer, because I did not know how to answer Eric's question, so I'm grateful for the insight that she shared. I actually wanted to answer, or at least offer some insights or thoughts about the other question he posed regarding what churches can do now or in the future to address the health disparities that Dr. Cooper so eloquently outlined. I think that, I think this is where the intersection of science and faith really comes into play, in the sense that we have a lot of evidence around the realities of these health disparities and the impact that they have on people's lived experiences. And I think in many instances, it's really easy to feel somewhat overwhelmed by these realities, or to at least feel a sense of hopelessness that they can change because they've been in existence for such a long time, and they seem so intractable in many ways. But I think, in terms of what we can do individually, there are certain things that we can do for ourselves to help ourselves and to help our communities. But I think a critical aspect of it is even maintaining awareness that they're occurring in the first place. I think one of the things that's really interesting about this pandemic is that for those of us who have had the opportunity to do health equity and health disparities research, and really, Dr. Cooper has been at the forefront of advancing this line of inquiry for a long time, we were well aware of these disparities, and so we weren't actually surprised to see that COVID-19 would exploit them. I think now that they're becoming more prominent in terms of what the rest of the country and the rest of the world is aware of, we now really have an opportunity to think about the root causes of these disparities and to think about what specific actions we can take individually as well as members of faith communities to address them. I'm really glad that Dr. Cooper highlighted the importance of voting. I think voting is one strategy. I happen to think knowledge is power in a lot of ways, and so just knowing these things is really critical. And then supporting others who are trying to address these disparities, whether it's frontline healthcare workers, community-based organizations, or even churches that are philosophically oriented towards really trying to ensure that there's some measure of social justice happening, and really see that as one of their responsibilities for just, supporting our communities and supporting the most vulnerable among us. And understand, too, that in some ways we have a faith directive to do so.
Thank you. Thank you. One of the comments that we have here, we've talked about vulnerable communities, and the LGBTQIA community has been named. One participant would like you to say a little more about that.
So the LGBTQ community, we've seen a lot of health disparities, particularly in youth. A lot of higher rates of mental illness, higher rates of suicide in those groups. In some cases, there are higher rates also of infection. And then they are at risk for biased treatment in healthcare. So that's why they are considered a disparity population. It's because of the disparities in some health conditions, but also in the treatment that they receive.
And if I'd also like to add a little bit as well, which is that I think it's also very important to acknowledge that some of the bias that members of the LGBTQI community have received have actually happened at the hands of religious organizations, which is why it's so important that we make sure that we are embracing one another and respecting one another, because some of the biases that they experiences in one setting carry over to other settings. We really have an opportunity to support those who are truly vulnerable in the society by virtue of things that are outside of their control. And so I think even that, I hope that what I'm saying now links up to what I said earlier about the role of churches and other faith-based institutions in supporting those who bear the brunt of some of these health disparities.
Thank you. Let's talk a little bit about the testing process. What it is, if a person has tested positive, how long they should wait before receiving another test, or even moving out into society. Will you speak a little bit about that?
Sure. So I think what we've learned is that there's the median time from exposure to developing symptoms is around 4 to 5 days. So usually by the time a person develops symptoms, they've been exposed already like 5 days before that. They get a test on that day, maybe day 5 or day 6. It's thought that they should quarantine themselves immediately. for at least another 7 days. There needs to be a total of 14 days of quarantine from the time of exposure to the time that a person goes out and is interacting with you. It used to be where we were, checking the antigen level to see if there was still viral particles, that the person was still carrying viral particles before we would allow them to come out of quarantine. But now it's been found that that some of those particles are not actual. They don't actually indicate that the person is still infectious. They are just like dead viral particles. So we're actually not at this point in time recommending like retesting of people. We're just recommending that 14-day quarantine period. And then if people are feeling well enough to, go back to school or go back to work, we're writing them notes to let them do that. But they still need to maintain social distancing, and they still need to wear their masks, because we know so little about this infection, and we don't really even know whether once you've had it and you have gotten some immunity to it, whether it protects you from getting another infection or not. We don't know yet. So, we err on the side of caution.
Thank you.
I hope that answered you.
No, it's very helpful. Thank you. And I just want to share, since you mentioned masks, that we do have a congregation, Bethesda United Methodist Church. They have a mask ministry. And so we will also make those resources available for those of you who would like cloth masks. This has been incredibly informative. And I am so thankful for the resources that you've shared. We've been asked if Dr. Cooper can share the resource slide with us once again before we leave our time today. Let's see here. Some folks also want to know if the slides will be made available.
Yes, we can do that. We can make the slides available as a handout to you. I'm just going to try to get you to the resource slide so that you can see the link. Healthequityhub.com, or actually .org, I think also works. And then as soon as you go to that page, you'll see a bar that says COVID-19 resources.
This is wonderful. If a person is uninsured or underinsured, are there resources that they can access via this website to get additional information?
Yes. If you look where it says for the community, and it says Johns Hopkins Center for Health Equity Community Resources, CF, if you click on that, that has a lot of different resources for people that are linked to, including those who are having, problems with healthcare access. I know in Baltimore in particular, Care First is working with Johns Hopkins and University of Maryland on a public-private partnership. And there's now a call center that has been set up by Care First. And so you don't have to have a primary care doctor to use that call center number. You can dial, I believe it's 211, or is it 311?
I think it's 211
or 311. And then you can ask whatever questions you have. You don't have to have a doctor to do that. And this PDF also has a whole list of a number of different resources.
Thank you. We will make sure that these resources are shared with persons on the call. If there are any other questions, we just thank you so much for joining us. We see here that Silver Spring also has a mask ministry. If there are others on the line, your church or congregation, faith community, if you all are providing masks, please let us know. Again, you can go to bwcumc.org /everyone counts. And there you can find more information about the upcoming webinars, ways that we can partner together, because what we're trying to do is we're trying to have resources that can be shared across the connection and shared even beyond the United Methodist Church so that we can be a support for one another. You've heard in the presentation today greatly about empathy. So we are one community. I'd like to just thank the committee, the Advocacy and Action Committee, thank Giovanni Arroyo, who is on the call today and working behind the scenes, along with Jan Taylor, Andrea Johnson, Dr. Sonia King, Tracy Collins, Rochelle Andrews, Ann Price, and Christy Latona. Thank you, St. James, for the work that you're doing in Howard County. I'm looking at the things that are coming up. one last question, I guess, before we go, since we have 1 minute before we leave. Are there any equity concerns in contact tracing?
Yes, I think there are. I think there are a number of communities that are going to be concerned about how contact tracing could be used in ways to harm them. So I think in particular, the immigrant community, I know is going to have a lot of concerns about that, and trying to make sure no one is going to be turning them into authorities. And we have a lot of, understandable mistrust in communities of color. So people may be worried about who's coming and who's calling to ask them, personal questions about who they've interacted with. And that's why Dr. Ibe and I have advocated very strongly with policymakers, with Democratic senators. We've been in conversations with health departments around the country, encouraging them to hire community health workers, people who are from those communities and who understand the issues and concerns of those residents and be sensitive and empathetic when they're contact tracing.
Thank you. Thank you both for joining us here today. Thank you to all the participants. We continue to pray for you, pray with you, and give God thanks for the work that you are doing here and around the world. God bless you. We will make these resources available to all who've registered. Thanks again.
Thank you for having me.
Thank you so much.
Thank you.